Hello, I'd like to introduce myself. I'm Sister Ellis. I work in the Discharge Lounge here at the Conquest Hospital, and today I would like to discuss with you about patient flow and discharges within this trust. The objectives today is understanding how patient flows through our hospital here, the challenges the trust is facing with discharges, knowing when the patient should be discharged or transferred, introduction to the Discharge Lounge, also patient criteria to use the Discharge Lounge / ward, understand the type of transport and availability for each one, the causes of aborted transport or discharges. Definition of discharge planning according to the NICE guidelines, March 2018. Discharge plan is a process of which ensures that patient has the right support when leaving an care environment. Therefore, the patient needs to be referred to the appropriate community services who manage their needs. Poor discharge planning can lead to poor outcomes. Patients will have to remain in hospital or re-attend A&E within 24 hours as a failed discharge, therefore taking up valuable beds within the trust. Patient flow. A patient is admitted to A&E. They could have problems medically or surgically. They then are admitted to a hospital bed for appropriate interventions. The MDT intervention team will get involved with assessments and are made by all healthcare professionals within the ward they're in. In complex cases, investigations would be needed for referrals or funding is to be made. Hospital bed is no longer required for this patient in the hospital. Discharge letters are needed. Tablets to take out, TTOs to be ordered by the pharmacy. Discharge referrals made for district nurses, etc., or any other agencies. Then we discharge the patient, arrange transport or arrange family to pick up, send to Discharge Lounge. With all this in mind, and if we do the flow properly, we will have 3 hospital beds for the next patient to use. So when do we start discharge planning process? When they're deemed medically fit, or when they're admitted to a ward, or admitted to A&E. The answer is C, when they're admitted to A&E, because the assessments are already in place. You know the background of the patient that's come into A&E. You know where they've come from, you know the reasons why they're attending A&E. You get a general feel of that patient's needs. What are the challenges we are facing at the moment? We are preventing A&E breaches. No beds being available in the trust. Patients waiting for discharge letters or TTOs. Waiting patient transport. All these have an influx on the patient experience. The Trust aims to reach 95% of patients to be seen under the 4-hour waiting time. At the present today, we're at 85%. We are here to free up the beds as much as possible in order to allow this patient flow. Aim to get patients ready for discharge. Aim to use the discharge lounge to wait for the transport. Aim to avoid patient complaints. Again, that falls back onto patient experience. Discharge coordinators. Most wards have one of these. And what they do is attend the board rounds and oversees complex discharges. They will speak to family members and try to establish their care needs. They will help and arrange care packages and work alongside adult social care. Complex discharges will check their home environment's suitability, checks into requirements for further rehabilitation or care facilities. The staff nurses on the wards require the unauthorised discharge letters or complete discharge letters. They will ensure all referrals are completed. The next of kin is also informed. They will liaise with the pharmacy staff to prepare the medication for discharge. They'll hand over appropriate patients to the discharge lounge. The pharmacist's responsibilities are: pharmacy technician will work alongside the nursing team to identify patients ready for the discharge and will check any changes to that patient's medication. They will liaise with the patient or the carers about their medication. They will help and give advice to doctors and nursing staff if required. Doctors, that's you guys. Some wards has a doctor assistant. They will help you do the discharge letters. But you may ensure patients are fit to go home. Create unauthorised or complete discharge letters. I keep on regards to the discharge letters because it's a vital component for appropriate discharge for that patient. So when do we discharge? When the patient is deemed medically fit to leave, after all the MDT decisions have been made, and when the patient, family or care facility can provide the support. That's highly important because they will bounce back. According to the NHS England, discharge, once a decision is being made that the patient is medically fit for discharge, the aim is then to get the patient to leave the hospital bed within 2 hours. It's quite a task to do. Here's a scenario of what's happened. Patient was in A&E, very busy, trust is on black alert, means no beds. A&E staff handed over the patient to the discharge lounge for transport home. Patient arrived in the lounge, transport was booked. Within 10 minutes, the patient became unwell and Metcall was sent out. Patient ended up back in A&E as a failed discharge. Transport cancelled in time to prevent abort transport. Here's another scenario. Patient has been waiting in a discharge lounge since 10 o'clock, waiting for the discharge letter and TTOs. We received the discharge letter and TTOs at 2 p.m. Patient's transport arrived to take the patient to a nursing home at 4 p.m. Transport called to say they are on their way back with the patient. Nursing home would not accept the patient. Why? The reason why is that the nursing home have a 4 p.m. curfew time. They will not accept patients. So it's vital to get nursing home patients home first thing in the morning. Well, this is the discharge lounge here at the Conquest Hospital. As you can see, it's an open planned area. Quite airy, quite bright, quite cheerful. We open Monday to Sundays, 7 to 7:30. Patients are only accepted up to 5 o'clock if there's no transport being booked because of the 2-hour window slot. I'll explain that later. Or until 6:30 if the transport has been allocated. At the Conquest here we have 10 chairs and 3 beds and an outside courtyard. Over at Eastbourne, however, they have 12 chairs and 12 beds. At both sites we do have a breakfast club at 7 o'clock, so there's no reason why we can't have patients first thing in the morning. We can give them their medication and breakfast. We do, however, have a patient criteria. We will accept adult patients from all wards and departments. All departments, outpatients department, when they close, we tend to accept after 5 o'clock. Those who are medically fit for the discharge. Patients that are confused may be transferred, but we really need to discuss the level of confusion that patient has. So an exclusion criteria, end-stage palliative care patients. These patients, as you saw in the picture, we're an open planned unit. To give the end-stage palliative care patients more dignity and respect, it's better they are on the ward. It's not very nice for those other patients that are sitting waiting to watch someone really pass away in their bed. However, we do accept palliative care patients, even if they have a syringe driver and they're not going to go very soon. Patients waiting for paramedic transport, that's your blue lights. We're not kitted out for that sort of scenario, so as you can appreciate, our neighbour is an outpatient, so we're not off a ward. And patients that are one-to-one, risks of absconding or distress due to change of environment. We found that learning difficulties patients, sometimes they can get distress on change of environment, which again we can negotiate. But we do have the learning difficulty patients down with us. Patients who have infections or require barrier nursing, once again we are open plan, so we can't separate these people. And we don't want to give the risk of other patients the infections. Patient transport. The Trust uses South Central Ambulance Service, called SCAS, British Red Cross, Impulse, Secure Transport, Kent Transport, for those out of area patients. SCAS is for all patients which need assistance to get home, taking walkers, single crew, double crew, stretchers, bariatric patients. Their policy is only 1 bag per patient of their belongings and a medication bag. Sometimes it's quite impossible when they're coming in for holiday, but we manage it. British Red Cross will take patients from the age of 18 years plus. And we tend to use these British Red Cross when the patient is home alone, but they need to be able to get out a 4x4 car. They will take home and settle the patient. So they will actually go off and do their shopping for them, making sure they have food in the car. They have even clothing. So they will make sure that the patient is well provided before they leave. Impulse, which is a private crew, I mainly deal with A&E, CDU and AAU patients and work from 10 o'clock in the morning. We can, with permission from the site manager team, to use these patients if we are really, really strapped with SCAS, and SCAS is really busy, to use them. But that we have to get permission through our site managers. According to SCAS data, March 2020 to March 2021, we had 368 conquest abort journeys. That's quite high. As you can see in March, bearing in mind this is a COVID year, we had 52 aborted journeys in 2020. We worked so hard in the discharge lounge to try and prevent those aborted journeys, and we managed to get them down to 17. We would like a 0 at the end of the day. This chart shows a number of discharges we've used for the patients over the year. Again, it's March 2020 to 21. In the red, you can see the pre-planned bookings. The blue is on the day bookings. We'd like to see a lot more red bookings. We are increasing slowly. You can see from March 2020, 53 was pre-planned, and we've gone up to 62. Out of all the numbers, 359 was on the day. We'd like the red to go a little bit higher. According to our data, the conquest here, in March 2020, we had 104 patients come through the discharge lounge. March this year, we had 256 patients. And I can actually say, hand on heart, last month we hit 360 patients. We are doing very well, but we want more. So what are challenges we are facing here? Ensuring that the patient is ready to go home when transport is booked. We're finding a lot of issues, discharge letters, TTOs, the patient's not ready. When the patient transport arrives on the ward, if they're going to the ward to pick up the patient, the medication is just not there. Discharge letter's not so much of a problem if the patient is going to the home address. Providing there's no changes to their original medication, then they can go home without the discharge letter and we can send it in the post. But ideally, it would be nice to have both together. To have this all in place will prevent any aborted transport, including COVID, most recent results at this present time. Nursing homes, as I mentioned earlier, has a policy in not accepting any new patients, sometimes even their old residents, beyond 4 o'clock. They will turn them around and send them back. Patient transport bookings. There is a 2-hour window slot for SCAS, for crew and to be picked up. So we've got to bear in mind in the 2-hour slot. Patient transport delays is inedible, road traffic, accidents. Last week I had one member of crew passed out in the discharge lounge, so we had to, so that was delaying that transport for that patient. She's all right though. So things happen. Ensure patients' bookings are correct. On the ward, some of the bookings been booked for patient transport. No one's looking at the property, whether or not their patient has steps to the property. If they got the keys, a simple thing as the keys to get in. If a patient needs a stretcher and they've not had a stretcher before, then the transport would need to go and assess the property, whether or not they can get this stretcher into the property. The stretchers from the 999 crew, when the patient comes into us, to the stretchers that we use are totally different. Totally different. So they have to go and assess the property. That will take time, and that could be a 24 hours. Bariatric stretchers, they take a 24-hour period to book, because sometimes, again, the assessment of the property is needed, and they may need other equipment to get that patient in. Aborted transport. Aborted transport costs the trust. Patient's transport, journey, and another overnight stay. 2 years ago, I asked the question on how much it cost for an aborted journey. If it's a patient stretcher 2 years ago, it was 50 quid, £50. I hate to think what it's like now. According to SCAS, in March 2021, 58 patients got alternate transport due to delays caused by nursing homes and discharge letters being late. Conquest Hospital, 32 patients were delayed due to discharge letters being late and TTOs incompleted and making the patient not ready. 25 patients were wrongly discharged and still too ill to go home. And 79 patients had wrong mobility, therefore wrong transport was booked. Quite high, really, quite high. Well, an ideal world is discharge letters to be completed the day before discharge date, even if it's an authorised one or the original copy. This will prevent any delays to nursing homes and hospital transport. Also, it will free up the beds, transfer the patients in the morning to the discharge lounge. We are there from 7 o'clock. Ensure the correct transport is booked for the patient's mobility and property access. Any questions?
What happens if, say, for example, we said the home, the nursing home closes at 4 o'clock? What happens to the patient if the hospital is on a blacklist?
The patient still come back, and the site manager will have to find somewhere for that patient to stay overnight. So the patient experience there is not great.
So the patient might end up on the corridor?
They go back to, if they can.
Yeah.
I have had the discharge lounge, because I've got the 3 beds areas. I have had the discharge lounge. It's rare, being used as an overnight ward.
And then you have overnight staff in there.
They have to provide the staff overnight. But they're the patients, they really got to scrutinise the patients. Because of the patients are deemed fit to go home, we only have a normal bathroom, we don't have a sluice. And our nearest ward is as you turn, which is opposite. And our neighbour is an outpatients department. So they've really got to make sure that those patients they're going to put in those 3 beds are really independent.
So, for example, what happens to those who are challenging patients? Say, one who's got geriatric and has got dementia.
If a patient has, with the transport coming back,
Yes.
yeah, it does happen. It's not very nice for that patient, but it does happen. That's why it's very important if we can lease at the discharge lounge, either we get to know that there is going to be a delay with the discharges, because we have got 2-hour window slot, so with SCAS, and if there is a problem, we have got other means of trying to get that patient out, but I need good time. My team needs a good time scale to work in to get that patient out on time. There's a lot of pleading sometimes with the nursing home, and to actually take the patient, if we can give them a time scale that the patient will be leaving, but at this time, sometimes they do try and say, yes, okay, we will accept. But other times they will say no. Because if it's a new patient to a nursing home, they've got to do their assessments on that patient. That is their understanding.
Sometimes this could happen 5 minutes past 4.
Yes. If it's 5 minutes past 4 and it's local, and the patient transport is turned up, we do have delays from SCAS from time to time, because SCAS is also doing the renal patients, so that's their main dialysis, that's the main thing. So we in the discharge lounge not only just look after the patients, we ensure and we keep a very close eye on what's going on with this transport to try and prevent any aborted patients. And we are doing successfully, because we actually brought the numbers down to 17. So it is mind-boggling. It is mentally challenging at times. And if we do find we're going to have an issue, then obviously we pass it up to higher above to let them know and be aware. And we have got private transport for that works in A&E, CDU, and with their permission we use those to get the patients out.
Thank you.
Thank you.